I'm Dr. Suresh Ramalingam, medical oncologist from the Winship Cancer Institute of Emory University in Atlanta. What is the optimal way to deliver chemoradiotherapy approach for patients with comorbid conditions, specifically renal insufficiency for locally advanced non-small cell lung cancer? When we talk about patients with locally advanced lung cancer, these are patients where the tumor either invades critical structures in the mediastinum or is associated with extensive mediastinal neural involvement. We do not view these patients as candidates for surgical resection, and therefore we use combined modality treatment approach. The combination approach we use is typically a platinum-based chemotherapy given concurrently with radiation therapy for stage 3 disease. This approach has been the standard of care for a long time. A number of different chemotherapy combinations have been studied. Now, more recently, we have also seen the integration of immune checkpoint inhibition after patients have completed chemoradiation based on the results of the PACIFIC trial. So durvalumab administered after combination chemotherapy results in a 5-year survival rate of approximately 43%. Clearly, we made good amount of progress in locally advanced disease. And in fact, curative outcomes are the goal when we talk about combined modality treatment for locally advanced non-small cell lung cancer. Now, if you take a look at specifically chemoradiotherapy part of this approach, one has to make a decision as to the optimal chemotherapy based on a number of factors. One, of course, is the patient's performance status. The second is comorbid conditions. The third is potential adverse events related to each approach and personalize that to the given patient. There are at least 3 different chemotherapy approaches that are available. One is the full dose chemoradiation therapy approach, where either cisplatin and etoposide combination is given with chemoradiation. This approach has been in use for over 30 to 35 years. This approach does have higher risk of toxicity events and therefore may be selectively applied for patients with very robust performance status who could tolerate this sort of an approach. On the other end of the spectrum, the weekly dose of carboplatin and paclitaxel with radiation approach has been adopted in a number of studies and is by far the most commonly used approach in the United States. This is what we refer to as the radiosensitizing dose of chemotherapy and radiation. This approach has very good results. The RTOG 0617 trial showed that even with the weekly carboplatin Taxol radiation approach, the median survival results were very robust. And then a third approach that's used is the cisplatin pemetrexed with radiation approach. This approach was studied in a phase 3 trial, and it showed comparable results to the cisplatin etoposide-based regimen. So all 3 approaches are available for clinical use. When a patient has renal insufficiency, then one has to be careful about what appropriate radiosensitizing regimen could be used. I clearly would not opt for either the cisplatin etoposide regimen because of the potential for even greater nephrotoxic effects, or the cisplatin pemetrexed regimen. As you know, pemetrexed is only to be used in patients whose estimated GFR is over 45 ml per minute. So as a result of that, I would not choose the cis etoposide or the cis pemetrexed. However, the carboplatin paclitaxel with weekly dose with radiation is potential for consideration. Taxol is primarily metabolized by the liver, so one could use weekly paclitaxel as a radiation sensitizing regimen. If you're using weekly carboplatin as well, remember it is dose adjusted for renal function. So to me, depending on the extent of renal disease, you could use the weekly dose of carboplatin and paclitaxel. If the patient has very severe renal disease, one could just use paclitaxel with radiation as well to improve the effectiveness of radiation. And finally, if the patient does have poor performance status and is not seen as a candidate for using any chemotherapy, then we would just use radiation therapy alone and consider a sequential approach if possible. So the decision really boils down to individualizing treatment approaches. It is important that we discuss with the patients the rationale for the decision and also avoid other nephrotoxic drugs when the patients are undergoing chemoradiotherapy in order to try and preserve. Obviously, Once you start treatment, you want to monitor the patient closely during every week, monitor the renal function. If you see sign that the renal function is declining, then we want to back off from the systemic therapy approach. On the other hand, if the patient's kidney function remains good and stable, then you can continue on with the approach that has been chosen. The more important message here is there is no one approach that fits all patients. We have to personalize treatments based on patients, and we have to be ready to modify the treatment throughout the course as the patient continues on with the treatment based on individual patient experience. The good news is long-term survival is possible even in the setting of comorbid conditions for patients with locally advanced non-small cell lung cancer.